To start today's conversation, I'd like to introduce a close friend to many of us and Acting Assistant Secretary of Mental Health and Substance Use at the U.S. Department of Health and Human Services, Tom Codera. Tom, can you kick us off by talking a little bit about how SAMHSA, CMS, and the Department of Labor coordinate on parity and why this is such an important issue?
Sure. Thank you so much, Bill. It's an honor and a privilege to be here with you and Patrick and Secretary Walsh and Commissioner Sullivan. The Kennedy Forum and Patrick, as its steadfast and passionate leader, continue to drive the national dialogue about transforming the behavioral health system in America. And our collective work on parity would not have been made this much progress without them. However, we wouldn't be here today if there wasn't more work to do, and SAMHSA is committed to working with all of you to ensure full implementation of the 2008 parity law. I want to acknowledge that in addition to being the Acting Assistant Secretary at SAMHSA, for today's conversation, a more important fact is that I'm a person in long-term recovery, which for me means I haven't used alcohol or drugs since May 15, 2003. And the reason I found recovery is because I had access to treatment. An irony is that I didn't have health insurance by the time I reached my final treatment episode. And thank God I didn't, because it qualified me for treatment funded by the state, which used SAMHSA block grant dollars to pay for my treatment. It meant that I received treatment when I needed it, for the duration I needed it. I spent more than 5 months in a residential treatment bed, which is unheard of today. This provided the foundation for the last 18 years of my recovery journey. What a privilege I was afforded. But shouldn't it be afforded to everyone who needs it? So as we approach today's conversation, I wanted to remind myself of that and all of you. And although SAMHSA has no regulatory enforcement role in the implementation of MAPIA, it has been a valued collaborator, partner, and a leader on parity. SAMHSA is a convener, a connector, and sometimes even an instigator. Our role is to reflect the needs and rights of the population we serve, and we bring the perspective of individuals with behavioral health conditions to the development of policy, stakeholder engagement, regulatory and non-regulatory guidance, compliance tools, products, and other implementation efforts. Parity is a difficult concept with asymmetric knowledge elements for people, especially people in sometimes desperate need of behavioral health services. SAMHSA served as a familiar and trusted voice for people with mental and substance use conditions. We try to reflect that voice in our partnerships with our federal and private sector counterparts. Moreover, we owe it to the people with behavioral conditions we serve. SAMHSA has actively supported MAPIA implementation by working closely with other agencies, as you mentioned, Bill, such as the Centers for Medicaid and Medicare Services and the Departments of Labor and Treasury, as well as with the Office of National Drug Control Policy and the Domestic Policy Council in the White House, among others. Externally, SAMHSA has an extensive reach to leverage in the behavioral health community to advance parity. We have worked to facilitate relationships with our state commissioners, with our single state agency addiction service directors, with NAMI and the Kennedy Forum, both of the APAs, the American Psychiatric and American Psychological Association, a host of others. And we continue work across government to encourage the full implementation of parity, like an interagency policy council that was recently convened with the Executive Office of the President, the Domestic Policy Council, CMS, the CIO, the Center for Consumer Information and Insurance Oversight, Treasury and Labor, which are going to help inform parity planning efforts. We also have been discussing collaborative ways SAMHSA can assist CMS in the review of state parity compliance efforts. On May 18th, Secretary Becerra at HHS hosted a behavioral health stakeholder event with the Assistant Secretary for Health, Dr. Rachel Levine, and myself to discuss HHS behavioral health priorities and actions, one of which is the reinvigoration of the Behavioral Health Coordinating Council, where we did significant parity coordination among our federal partners. So in collaboration with CMS, the CIO, and Labor, we're also finalizing 2 publications with the goal of publication this summer. One is a parity training tool for state regulators and behavioral health staff, which provides an overview of essential information necessary for understanding parity and how to implement and comply with federal parity laws. And the other is a parity reference guide for family members and caretakers, which provides an overview of essential information necessary for understanding parity. Finally, we're encouraged by the Biden-Harris administration's commitment to full implementation of MAPIA. We also know that parity is a bipartisan issue. There is renewed excitement and activity at the highest levels of government. We will likely see efforts and resources dedicated to push us all forward on parity. The administration's significant investments in SAMHSA and across government are a reminder that now is the time if there was ever one. Working together, we can make sure those investments reach a system that is equitable, accessible, free of stigma, and at parity. Thanks so much for allowing me to be here with all of you today.
Thank you, Acting Assistant Secretary Coderre. We are grateful for your leadership as well as your personal courage in talking about your addiction. So thank you so much. Now let's get started with our panel. Audience members, feel free to ask questions in the chat feature as we go, and we'll try to address as many as we can at the end. Congressman Kennedy, let's begin with you. You were the lead author of the bipartisan Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act of 2008. That's a mouthful. While in Congress, the landmark law that prohibits discrimination in health insurance coverage of mental health and substance use disorders. Why was this law so foundational to building the mental health system our country needs? And what else needs to be done?
Thanks so much, Bill. Over 60 years ago, President Kennedy was the first president to go on national television to call out civil rights as a moral question, because he said, who amongst us would be willing to trade the color of their skin and then be content with those who counsel patience and delay? We're in the same spot today. There's many people who tell us, take your time, let's get more administrative rules, let's get more clarity on non-quantitative treatment limits. There is delay, delay, delay. Over the last decade, when we have had parity, we have had a number of strong rulings at the state level. And I would ask if that slide go up, we can show people that many states have enacted enforcement action on this federal parity law. But I think we know the reason why it's been so difficult. And the reason has been that there have been too many with mental illness and addiction who have felt the shame and stigma of having those illnesses and who've not felt comfortable pushing back. Frederick Douglass said, power concedes nothing without demand. It never has, and it never will. And as Secretary Walsh knows, as a labor leader, we need power in our numbers to push back against this discrimination. Because in essence, the Mental Health Parity and Addiction Equity Act is a modern day civil rights law. It says that you can treat illnesses of the brain and those who suffer from these illnesses no differently than you would treat any other person with any other medical condition. And so now is the time for us to not only hear from the state regulators, the state attorney generals, it's time for us to hear from the federal government. And I couldn't be more proud, Mr. Secretary, to be on a call with you, with Tom, my other friend in long-term recovery, and I know there are many others who are on this call, but we have a unique opportunity, Mr. Secretary, to speak up for those who are in the margins, who are silent and shamed because of their illness, and to fight back against those who would discriminate. We haven't changed racism in the last 60 years since we passed the Civil Rights Act. But what we have done is we've outlawed discrimination. We've outlawed people acting on those bigoted thoughts. We are not sure whether we have overcome bigotry and attitudes towards those with addiction and mental illness. But one thing's for certain, we have outlawed anybody acting in a discriminatory way. And so that is the nature of today's discussion, is enforcement. We have a good law. But as we all know, if that law is not enforced, it's not worth the paper it's written on. I want to thank Commissioner Sullivan for her long service in this space. Bill, thank you for all you're doing to launch Inseparable and renew our advocacy. Tom, my great friend and fellow in recovery, and of course, Mr. Secretary, thank you. And I'd be really missing if I did not call to mind my great partner in this journey, Jim Ramstad, who passed away several months ago. And I'll say something about Jim. He represented the largest insurance company in this country, United Healthcare, in his district. And he was the leading proponent of the Mental Health Parity and Addiction Equity Act. And he has been a friend both while he was in Congress with me and since. And he never stopped wanting to make sure this law was enforced. And I just think he is a profile in courage as we approach the anniversary of President Kennedy's birthday and the Profile in Courage award is given out. Jim Ramstad stood up because he saw too many of his fellows die needlessly because they were discriminated against by their insurance plans. To think that he fought, even though he had the largest business in his congressional district, was the largest payer in this country, is a humbling thought. And I'm humbled today to recall his memory and to also indicate that this is a bipartisan fight, as you said at the outset, Bill. So thank you so much for helping me set the context for today's discussion. I appreciate it.
Terrific. Thank you for that. Secretary Walsh, we're seeing unprecedented demand for mental health and addiction services. COVID has really poured fuel on the fire that was already raging. And many Americans likely don't know that the Department of Labor regulates employer-sponsored health plans. Can you talk about why mental health is so important right now and the department's role in ensuring that people can access the mental health and addiction services they need?
Thank you, Bill, and I'll get to that. I'll get to that answer in a second. I just want to say thank you to you for moderating this conversation. To Commissioner Sullivan, thank you for being part of this great panel. To Tom, as Patrick Kennedy said, thank you. You're a great guy, a great man, and thank you for the conversations you and I have had already about what we can do inside the government. And to Congressman Kennedy, thank you for this fight. You and I had a conversation probably about 8-9 years ago and talked about this, and it's such an honor. Life is amazing, one day at a time. You don't know where you're going to end up, and it just so happens that I happen to be Secretary of Labor today, a day at a time. So thank you as well. Bill, you know, the pandemic has certainly opened our eyes to how important these issues of mental health and substance use issues are. As I often said when I was the mayor of Boston when the pandemic began, I would often end my press conferences with a message, and my message was to people that are struggling with mental health and substance use issues, because the pandemic was in some ways we were telling people to isolate, and it made those issues so bad. We have an opportunity to make progress. From early in the pandemic, we saw the need to make mental health support a focus of messaging in Boston and across this country. For me personally, as I said, it goes back to my personal experiences. Treatment made a difference in my life. I had the opportunity, as Tom talked about treatment, I had the opportunity to access treatment. I had the opportunity to go to a program and get an understanding and foundation for my own personal recovery. And that's something that's important. One of the things that excites me about this current job is that the Department of Labor is the primary regulator for private sector employment-based health insurance. And when I was being rumored for this job, I was online, I was Googling through the Department of Labor's website, and the very last bullet point was mental health parity. And I thought to myself, wow, that's going to be good because I think it's important. And at the department, we take the responsibility very seriously. From day one, after I got sworn in, I emphasized that our enforcement in this area needs to be a priority. In December, the department got some new tools to enforce the mental health and substance use parity provisions of federal law, and we intend to use them. Group plans and insurers have to be able to show their work if they're claiming to meet parity requirements. And if they don't agree, they're going to have to tell the people in all those plans. So we do have a unique opportunity. And for the folks watching, the other day I had a conversation. We had a little kind of brief conversation, and I was talking to Patrick about this, and you know, this is the work that excites me in a lot of ways, because I know right now, as we're doing this webinar, there are people trying to access treatment in this country, and they're ready to access treatment. And I think we need to make sure that we meet those folks when that they're ready to make that call, or a family member is desperate need to get somebody into help and treatment. They need to be able to access that. So I look forward to this conversation. Thanks for having me here today. And Bill, I'll turn it back over to you for now.
Thank you so much, Mr. Secretary. We are really grateful for you for sharing your story, and for also making sure that mental health is not just the last bullet. So we're fired up to have you as Secretary of Labor. Commissioner Sullivan, in addition to heading New York's Office of Mental Health, you're a practicing psychiatrist. So I'd love to hear about your experience both in private practice and in government with the reality of mental health parity compliance on the ground. I think it gets a little lost in wonky conversations sometimes, but if you could talk about how that plays out on the ground.
Yes, thank you so much, and thank you for inviting me today. It is a real pleasure to be here with the true champions of parity, like the Kennedy Forum, like Secretary Walsh, Tom Cordero, who's been tremendously helpful to us at the states, and Congressman Kennedy. Thank you so much. I mean, we can't thank you enough for all the work you've done. That's from the ground saying thank you. I think, you know, access to care is still a major issue. 50% of individuals with mental health treatment who need mental health treatment in the past 12 months didn't get it. And a big piece of that is, part of that is parity and insurance. And on the ground, what you feel are a number of things that medical people don't feel, like excessive prior authorizations, that you have to go have multiple treatment plans that you may have to submit as a provider for a patient, where a primary care doctor wouldn't have to do that you have to worry about whether or not there's a network. The individual calling, you know, I still get tons of calls from individuals who say, I've called all the people on the list in my plan, and I can't find a psychiatrist who's available, or I can't find a child psychiatrist who's available. The burden falls to the individual. The burden shouldn't be on the hands of the individual. The burden should be on the plan to make sure that that network is adequate. And when you say to someone then who doesn't know who to call, we'll find an out-of-network provider, that's not so easy. They have to then find someone out of network and have to then connect all the pieces. And sometimes the individual client, the patient, has to be calling about all this to their insurer, who's not all that helpful often in making sure that an out-of-network provider is available when a network provider isn't available. So the basic access points are hard. And if you just to give you a few examples then of someone who's seriously ill and on an inpatient service, and the doctor is saying that this person came in suicidal, and maybe today, 2 or 3 days in, they're not as acutely suicidal, well, that might be a call from an insurance company to say, well, if they're not acutely in imminent harm, then they shouldn't be in the hospital any longer. And you have to now defend if that person needs to be there for a week or perhaps 2 weeks, or to get the kind of care that would be needed to get a stable discharge plan. It doesn't really follow the standards of care. And then you have these conversations with the providers. Sometimes then you get denials, and who pays for those denials? Healthcare systems. Providers lose money, and sometimes it even backs up to the patient to have to think about those denials for care. So there are multiple issues that happen. The reality is that the access isn't there. If you look at access to care for diabetes, it's about 22% of individuals don't get access to care. It's double for mental illness. So there's something embedded in the way our system of care provides services that that doesn't deal yet with the discrimination, et cetera. And then last one other point, you know, when systems of care are underpaid, when providers are underpaid, what happens? Beds don't get opened for inpatient care. Substance abuse services aren't available because hospitals have margins and they have to worry about dollars. And when those payments aren't sufficient, we in New York are constantly discussing with our systems of care, keeping beds open and available to individuals who need the care because the reimbursement isn't adequate. So that's the other piece, and that's a long-standing issue. Parity has some place in that as well, just to make sure that there's not discrimination in terms of how you design that payment for parity, payment for mental health, but it's an issue across the system of care. So there's many things that affect the system, the provider, and most importantly, the client, who then has trouble actually getting the care they need when they need it.
Thank you, Commissioner. Sort of continuing on this this idea of the barriers to accessing care that the Commissioner referenced. Secretary Walsh, in late 2019, the GAO issued a report that questioned the effectiveness of regulators' parity enforcement efforts and suggested that regulators were too reliant on receiving complaints before checking for compliance. Can you discuss a bit about what DOL is doing to devote resources to parity compliance and where you plan to focus the department's enforcement efforts?
Sure, thank you. I've made it clear to the team that we need to prioritize the issue, and I don't think I didn't needed to do that. They certainly have done it themselves. We have already revamped our approach to enforcement. As the president's initial budget shows, President Biden's administration is making historic investment in worker protection programs, including enforcement work at the Employment Benefit Security Administration, EBSA. EBSA has embraced the challenge. It's created a task force on enforcement of the Mental Health Parity and Addiction Equity Act. It's reviewed its inventory of cases for potential violations. We've hired experts to lend assistance and send out dozens of requests for plans parity analysis. We certainly, as I mentioned earlier, absolutely intend to enforce the law's parity requirements. We're also going to be reporting out our findings to Congress. I should mention that we're not in this alone. At the federal level, we share jurisdiction and coordinate with the Department of Health and Human Services and the Internal Revenue Service and the Department of Treasury. And the states have their own roles to play in these issues. As the Commissioner just said, in some cases, they've really been leading the charge. If we're going to be successful, we need to be working together to achieve the law promise of parity. If we're being honest, it's long past time. Patrick, you talked about it in your opening remarks. I know folks have asked whether we have all the enforcement authority that we need. Right now, our focus is getting everything we can do out with the new tools we have to consolidate from the Consolidated Appropriations Act. But just trust me, and anyone that knows me, if I think we need more, I'm certainly not going to be shy, and people are going to absolutely hear about it. And this work that we're doing is life-saving work. Many of us in this panel have lived it personally. People that are watching and listening are living it maybe right now. So we're going to do everything we can to make sure that we meet this moment, and this is the moment in time for us to really make some big gains and take some real action.
I like saying that it is life-saving work, Mr. Secretary. That's a great way to put context to this. Commissioner Sullivan, the Office of Mental Health has been deeply engaged in enforcing the federal parity law, both for the fully insured commercial plans and Medicaid managed care plans in New York. Can you talk about how you've gone about the process of evaluating plans parity compliance and the violations that you found and the actions then to improve access to care through that process?
Yes, I think we've been very proud of, from our governor through our leadership throughout the state, to take on parity. And I think what we've decided is that it has to be a comprehensive approach. You can't kind of just pick at pieces of the parity legislation, which is good legislation. And also all the work of the various toolkits and things that have been out there by the Department of Labor, et cetera. But you can't pick at things. You have to do a comprehensive approach. So what we've done with our government plans is that we have mandated that they work with us on all of the quantitative limits, which people work on for a long time, but that they also work with us on all the 19 of the non-quantitative treatment limits. I always get those words, but that is critical. You can't pick one or two. You really have to say to a plan, you have to change the culture of a plan. You have to say to a plan that you have to look at how you are treating mental illness and substance use the same as medical. And the reason why we have 19 NQTLs is because all of them are important. So you have to have a comprehensive approach. So the first is that. And we went to a comparative analysis with our Medicaid plans, and when we pulled all those plans in, none of them met all those requirements, none of them. And I can honestly say that most of them have not been doing comparative analysis that really had any teeth in it at all to really look at what was going on. We then contract with Milliman and others to work with us, to work with the plans to develop a comparative analysis. This is the kind of detailed in the grass work that you have to do to really make a change in the way people work with parity. And I think we'd be doing a similar thing with the commercial plans now. We started with our government plans, and now we're working with the commercial plans. So that's critical that you do comprehensive. And then you have to be thinking long-term about enforcement. And although we haven't gotten there yet, because we're still at the place where, I think in June, some of this is actually going to come into work. It took almost 2 years to get some of this done. The second piece is to have a really robust way for staff and clients and everyone to still bring forward issues. And that's an ombudsman program that the state has financed as well. So parallel to all the hard work of looking at what the plans are doing, we have an ombudsman program where you can call in. We've had over 4,000 calls where we have lawyers and others who work with individuals to make sure that they get basically the care that they need through the plans. And simultaneously, that gives us a little bit of a sense of feet on the ground, what's happening across the state. So the key thing here is a comprehensive approach. And you can't just take it 1 or 2 points. You have to look at the whole approach to parity. And you have to look at all the things that can interfere with clients getting the care that they need.
Thank you for that, Commissioner. You know, Congressman Kennedy, too many families have had the experience of their loved one needing ongoing mental health or addiction treatment and having care limited by their health plan. I really like the commissioner's notion of changing the culture of plans. I know in my own family, my brother required inpatient care. A doctor prescribed a certain length of treatment, and then the insurance company only allowed for less than half of that. And many families are left with the same kind of questions. Is some care better than nothing? You know, what's the cost of treating my family member? It's really complicated for people who are in tough situations. And there's also been a very important federal class action lawsuit in California, WIT versus United Behavioral Health, that found the nation's largest insurer wrongfully denied coverage to more than 50,000 Americans, half of whom were children and adolescents. The court detailed that United used medical necessity criteria that were inconsistent with generally accepted standards of care and were used to mitigate compliance with the Federal Parity Act. Why has this court case been so important? And what's been the response from the mental health community?
Thanks, Bill. I think this court case is kind of like our Brown v. Board of Education. It is a moment in time. It's Exhibit A to what Commissioner Sullivan talked about in terms of how plans often substitute their own medical management practices for those that are generally accepted. In other words, they're making up their own medical standards. They never went to medical school, unlike Commissioner Sullivan. They don't spend years and years of their life studying this. And they're doing it, according to the WIT decision and the federal Judge Spiro out there, to make a profit. And what's really perverse about this is we know that the cost of them not treating people is so high, not only to the families and the rest of the medical system, but to our society as a whole. This is an existential moment. We have longevity increasing for all Americans thanks to the investments we made in all areas of medicine. That is being challenged and actually seeing reversals because of our mental health addiction crisis. This is not just a law and a parity issue. This is a national security issue. Businesses in this country have an obligation to have their workforce fully productive. That cannot happen if they are inadequately, if they got third-party administrators that are not following the federal parity law. And I'm not holding out the law as some great model. It's really the floor, not the ceiling of what insurers should do. So this conversation is so crucial. The WIT decision is, I think, Exhibit A of what we've seen, frankly, from many payers. And the earlier slide that I put up showed that frankly, all the payers have been stung with judgments that are very similar to WIT, where they were found to substitute their own medical management practice or impose pre-authorization in a way that they would never do if it were some medical or surgical issue. And you can see on this, not just a single United out, but, Cigna, Blue Cross, Aetna, all of the big payers. So this has been endemic as an industry, and that's why we need to treat it as a systemic problem, and why having real consistency from Secretary Walsh and his now enumeration of how EPSA, Employee Benefit Security Administration, is going to take this on. We as consumers, we have parityregistry.org, otherwise known as don'tdenyme.org. We as consumers and families of consumers need to support Secretary Walsh and Commissioner Sullivan by giving them our own stories. And we need equivalent of an NAACP for this fight for civil rights, for parity. I encourage people who are in the chat box who have their own stories of feeling as if they were wrongfully denied, please share your story on parityregistry.org. We can give these stories to Secretary of Labor, to Commissioner Sullivan, and to her counterparts around the country and say, here are the families in your state who have, by the way, very similar stories of denial. And guess what? That's enough for an attorney general or commissioner to instigate an investigation as to whether there are patterns and practices of discrimination in that state. And to the point of United, that may have been a case in California, but Rhode Island found the same pattern of medical management practice abuse. And it was sparked by the WIT decision. And guess what Rhode Island did? They canceled their largest state employee contract. And Secretary Walsh knows what this is about, because it's the way organized labor uses the power of organization to push back and say, we're not going to stand for it. And if you continue to do this, we're going to not only enforce the law, but we're going to put political pressure on states to deny those plans access to our state's residents, because that's a privilege plans have. They don't automatically get a right to sell in our states. That's a privilege made by the state's legislators. And if those legislatures feel that those plans are discriminating against this issue, existential issue of our time, then they have the authority to deny that plan entrance into that marketplace. And if that starts happening, then I think we're going to finally start to see some of these plans change their course.
Absolutely. And that all comes down to leadership. And that's why we are so grateful to have the Secretary and Commissioner with us. Commissioner Sullivan, you started working on this issue of medical necessity that we were talking about prior to the WIT ruling. Can you describe the review of medical necessity criteria that you've done and the results of that, and how you see putting in place, stronger rules on medical necessity that help increase access to care?
Yes, thank you. Congressman Kennedy, you're absolutely right. I think one of the big keys in parity is this medical necessity criteria. And medical necessity criteria should follow acceptable standards of medical practice. That's the key word, acceptable standards of medical practice, which have been established by medical societies, have been established across the country. It's not hard to get your hands on what those acceptable standards should look like. There's a tool, for example, called the locus for adult, the cow locus for children. It exists. The question is, how do you have those tools, the ones that are used? In New York State, I think we have one piece, which I think is really good, is that we passed a law that said that the medical necessity criteria of every plan, both commercial and Medicaid, had to be approved by the Office of Mental Health. And the utilization review criteria have to be approved by the Office of Mental Health. We went out and we offered things like the locus or other tools, but we said, you're going to have to give us, if you're not going to use those, then you're going to have to tell us how you're going to do this, and we have to review it. And I say there was pushback. There was tremendous pushback on this, but it's happening. We now have 25% of the plans in the state totally aligned with us. We've got about another 30% who are working very closely with us to make sure that they actually use acceptable standards of care. And what does that mean? That talks to what I talked about earlier. For example, there was a kind of hard to believe, truly, that if you were on an inpatient unit and you weren't improving, this was not unusual in managed care plans, and you weren't improving, that you could know that there was a denial. You weren't getting better. And therefore, on basis of medical necessity, why should you be treated? Which is the most perverse kind of logic that you could ever think of. That if someone isn't getting better, obviously the treatment is more important. So the reality is those kinds of peculiar standards which existed in the proprietary medical necessity are totally inappropriate for anything that has a medical standard of care. And that's where we're going. And I think if states do this, now it takes manpower, it takes money to do these reviews, so states have to invest in it, but it gives us the opportunity to really get to what's critical here, which is how are you deciding what kind of care is needed? And you have to follow acceptable medical standards, as the congressman said. And now we've got the agreements going forward. We have a number of things. Also, utilization review was included. So utilization review practices. The common thing that every inpatient psych admission is reviewed is crazy. I mean, nobody else gets every inpatient service reviewed. So we're working on utilization review. That also has to be approved by the state. So as we move forward, I think that those are the things that can actually change and follow up on what happened with the WIT decision, follow up on all the key advocacy on medical necessity. But again, you have to have a plan, and then you're going to have to enforce it. So one of the things we're going to have to do, and the state has the dollars to do this, is check that after all these plans now have the right medical necessity criteria, that they're actually implementing it.
Absolutely. Well, Secretary Walsh, we have hundreds of mental health advocates that are joining us today. And we've been kind of peppering you and the commissioner with all these questions. But I wanted to sort of turn the tables and say, what can we do to help you and the department increase access to health and addiction care?
Well, first of all, let me thank all the advocates on the call today. I know that many of you have been doing this work for a long time. Without you and without your support, and without people like Congressman Kennedy, we're not having this conversation today. And I think that, you know, I've indirectly worked with this space for a long time. And, you know, having people, passionate people that care, that have the lived experiences or have worked with people, thank you for what you do. We all have a role to play in certainly raising awareness and reducing stigma. That's something that we need to do every single day. I want to say thank you for your passion. I want you to know that we're going to continue to keep paying attention to these issues. I want you to know if you see areas of abuse, I want to let us know. And if you have ideas on how we can better enforce the law, let us know. This is one of the areas, when I say this, I'm not saying it in a bad way, but it excites me that this is within the Department of Labor's purview, because it's certainly an issue that I care deeply about, both personally, professionally, in understanding the millions and millions of Americans all across this country that are suffering. So thank you. And my last message is thank you for the work you do. Truly appreciate it from the bottom of my heart.
Wonderful. Well, we're going to take some questions from the audience. We've had a lot of great questions. I have one for Commissioner Sullivan here. We lack good claims data on issuers' coverage of mental health and addiction services compared to medical services. New York is attempting to pull back the curtain and show how insurers are covering mental health and addiction conditions. Why is having good data on mental health and addiction coverage so important?
I think the data gives you an incredible tool in terms of working with the managed care plans, but it also gives you a transparency to the public. And I think what we have is a data reporting system in New York State where plans have to report things like number of paid claims for mental health versus number of paid claims for medical surgical services, number of denials for medical versus denials for mental health and substance use services, the number of appeals overturned. Now, some of the data is on the website now. It's public, and that had to be reported last year. What we're working at is making it a little more user-friendly for the average consumer, for the person who needs mental health services, because the way it's displayed right now, if you went on, you might still have trouble figuring out who are good players on Parity and who are not so good players on Parity. So I think we're working on that, but the reality of having the transparent data is critical. It also lets you look at variations so that you can work more and more with plans that aren't meeting the goals you want. So for example, if someone is very high on the denials and then overturned appeals because basically those denials were found to be inappropriate, that's a plan you want to work with. And that's a plan you want to go in and find out and do the comparative analysis and work with them on what are you doing wrong here, because you shouldn't be having so many of your denials overturned. Or if you have a low percentage of mental health claims paid, why? What's going on? And then you go in and you work. So the data gives you that foot in the door, and it also helps you to be a little more objective about what you're doing and know that you're being careful, but at the same time gives you ways into knowing what's there. And hopefully we'll also have it in a format soon that the public can also understand that.
Next question here for Secretary Walsh. What will the U.S. Department of Labor do to ensure payment parity for telehealth for mental health for the ERISA-regulated self-insured plans?
Yeah, thank you. First of all, I want to thank Commissioner Sullivan for her thoughts and that previous question, and I would love to have a follow-up question, but that's not my role today. So at some point, I'm going to have to call you because the denials are just, in some cases, absurd. Certainly what we're doing right now is EBSA is working on in telehealth, looking at insurance plans, looking at insurance companies, working on telehealth. There's been a lot of telehealth that has been increased during the pandemic, and we're looking at what rules and regulations and jurisdictions we have there, and seeing how we can make sure that similar to what Commissioner Sullivan just said, making sure that we're not seeing people deny treatment and access to treatment, whether it's telehealth in person as we move forward here. So we're going to continue, and the Consolidated Appropriations Act obviously is an important tool for helping us with enforcement as well.
Great. Congressman Kennedy, question that came up when you were discussing the WIT case. How can we be ensured that United Behavioral Health is processing the denied claims? Is there any accountability there?
Let me just take one step back because I loved Commissioner Sullivan's really deep dive on all the analytics. The good news is that the Millman report analyzed 46 million payer claims data. The Millman report is not some bastion of liberalism and not some foil for the Democratic Party. This is a conservative business analytics firm that showed demonstrable differentiation and disparity amongst access to mental health and addiction vis-a-vis medical and surgical. So all we really need to do is take that as a supposition, add on top of it all of those cases I outlined at the beginning, which shows this is not an isolated case. Throw in WIT, and now I think the burden of proof is on the payers to defend themselves against the assumption that the parity is not being followed. And I think in the past, unfortunately, the burden of proof has been put on the consumers to somehow try to fight the big insurance companies and to do it while their loved one is suffering from a mental illness. And so I think that this is like the civil rights fight. We have to pick and choose our jurisdictions. I want everyone on this call to know that by fighting for parity in your jurisdiction, in your state, you're going to be helping our nationwide fight for parity. Because when New York does some powerful moves under Commissioner Sullivan's leadership and all the work that they've done, you know what? It sets a national standard. If payers have to comply in New York City, some of them just throw up their hands and say, we might as well just do it nationally. And if we can get this decision right, and it's tragic that United decided to appeal this decision of WIT, which was so clearly a case where they were caught in a transparent way, substituting their own medical management practices for those that were generally accepted, then, that is going to have a ripple effect. And so everybody, and I'm seeing in the chat box, tons of stories. I want to tell my story. Again, go to parityregistry.org, don'tdenyme.org, tell your story. Let's support each other. That's how we do it in recovery, and that's how we're going to do it in this fight to stop discrimination against our fellows.
So many questions in the chat box around access. Here's one. What is being done to control or standardizing what behavioral health entities can charge? My daughter was in treatment at the age of 19 with no insurance. A 30-day stay in a cost at Wickenburg, Arizona facility was $150,000. For her to get admitted, she had to come up with $45,000. This is not achievable for most people. Advice for our questioner there. What can we do to address standardizing what entities charge for this service?
Let me just jump in real quick. I mean, we clearly still have a lot of work to do. I mean, there's no question about it. I think when we talk about parity and how do we meet parity, everyone has a different definition of parity. My definition of parity is that somebody needs treatment, they make a phone call, they call EAP, they call their doctor, they call their insurance provider, they get an opportunity to go in and get treatment. And again, as I said earlier, when Commissioner Sullivan was speaking earlier, when she was talking about the amount of claims denied, I mean, I know I'm preaching to the choir, but people that don't understand this, when somebody is struggling with mental health issue or a substance use issue, and they make the phone call or the family makes the phone call because their loved one is ready for treatment, that's the moment treatment needs to happen. You have to happen at that moment, because if you wait a day, if you wait an hour, your loved one might be in a different place and might decide not to go into treatment. And I think that, I've heard those stories here where family members were going to send their loved one for treatment out of the state and pay out of pocket all this money. We need to do a better job. We do need to do a better job as a society, as a country, as individual states, as the United States. And again, on the specific question, I don't have a real good answer for you. Maybe Patrick does, or the commissioner does, or Tom does. But all I can say to you is that we're going to be working at the Department of Labor across agency lines to look at how do we change that? How do we change that so families have access to good care for their loved ones at a cost they can afford?
So, Mr. Secretary, the Purdue Pharma just got sued, obviously, for overly marketing and a clearly addictive product, and the lives lost. We need to have payers step up and really make sure that they have adequate reimbursement to Commissioner Sullivan's original purpose. If you don't have enough providers in network, it's because you're not adequately reimbursing in network, and you're forcing people out of network to pay higher co-pays and deductibles for going out of network. That's a parity violation. But more importantly, they have had historic discrimination. So this is not simply about meeting the letter of the law tomorrow. Payers have to take a real reassessment of their past discrimination and say, now's the time for us to rectify that by adequately investing in access, which means we've got to do a lot better to ensure that people are not stuck having to go it alone, which is the current system out there. And they have an overarching obligation, aside from parity, to make this right, especially as suicide and overdose are such national epidemics themselves.
A comment came in the chat box, Patrick, that a slightly different angle on this. Said, I appreciate the efforts for coverage parity and denials, but just as important in being lost is payment parity to providers. That's why you can't always find providers in network. Plans purposely underpay providers. Providers leave the network and go to cash basis only. How do we address this? It's not just medical necessity.
I think that's a critical point. And, the prior question too, my experience, now I don't know about the particular service that was received, but my experience is that behavioral health providers, price things no differently than any other medical provider does. So the cost of care is something that is priced based on by and large cost, but then some degree of margin perhaps. And often behavioral health is priced lower than others. The big issue here is who pays for it. And the reality is that some providers will not take insurance because the insurance won't pay enough. So there are, for example, even some residential services that will say that you have to pay cash up front because we don't take insurance. And why don't they take insurance? Because the insurance doesn't cover the cost of the care that's provided. And that's where parity comes in big time. First of all, you should basically cover all the services you need. But then there's parity for payment, and this one's tricky. And I think it's important to look at how an insurance company, and this is where parity can be helpful, how an insurance company determines what they pay for behavioral health service versus what they pay for a medical service. And you will find discrepancies. You will find things like maybe for medical service, they pay 120% of Medicare. For behavioral health service, they pay 60% of Medicare. So you really do find disparate ways that managed care, that companies decide how they pay. And that's where parity can become important. The important thing here is that when you have an insurance plan, you pay. As a consumer, you pay. You either pay for your employer or perhaps you're on government. You expect to be able to get the service you need. And what's happening here is a combination of factors, but one of them is payment. And then if there aren't enough, you aren't paid well enough, you're not going to have enough providers even available to kind of provide the service, and you get into that whole access issue. So yes, I think while yes, costs have to be reasonable, the bigger issue is who's paying. And when insurance companies don't pay, it often falls to the client, the family, the patient to have to pay. And that's just unacceptable.
One more question here. Can anything be done to address inflexible requirements for residential treatment that some health plans require, such as 24-hour on-site clinician, weekly psychiatric sessions, mandatory accreditation with specific agencies, pre-authorization, exclusions for outdoor programs, et cetera? Can we get clarity from the Department of Labor on these issues?
I would have to get back to you on that answer, to be quite honest with you. Again, I would have to, let me, if you get me the information for the person who asked the question, if they could throw your information in the chat, I'll get back to you on that answer.
Thank you. Yes, we have a lot of highly technical questions, a very smart audience that we have here this morning.
Yeah, I can't even begin to just try and couch that where it sounds like I know what I talk about. So I'd rather just be honest up front and say I don't have the answer unless Commissioner Sullivan has the answer. I'm gonna leave that one alone.
Didn't mean to ask you the stumper there.
Thanks, Bill. I appreciate it.
Another one on the Department of Labor task force. Are there family members or consumers of services or constituents in recovery who are a part of this Department of Labor task force?
Yeah, there's going to be lots of advocacy and input by people. You can't have a task force if you don't have real lived experiences and life experiences. So there's going to be lots of opportunities for people to be able to if you're not on the task force, to be able to talk about your experiences. And I think, you know, the website, the website Patrick was just talking about as well, getting those stories are really important to us as well, getting into the Department of Labor. I mean, we're going to be reading them and seeing them. I think that's going to help us moving along here.
So we've had a fantastic discussion, and I really appreciate you all taking the time today to have this conversation, and to all of our guests for so many wonderful questions. I want to ask each of you to give us a quick 20-second or so final thought about parity, or just kind of a closing thought today. And I'll start with Commissioner Sullivan.
First of all, thank you for having me, and thank you for this discussion, because I think, you asked earlier, how do you change things? I think it's with forums like this, and I think it does take the input of so many people. It takes the Department of Labor, it takes our legislators, our politicians, it takes our consumers, everyone. So we really all have to work together. You know, it's time to end the discrimination against mental illness. That's truly what it is. It's been around for a long time, and mental illness and substance abuse still have tremendous stigma. and basically are discriminated against in so many ways. It's time to kind of stop it. And Parity is a huge tool, a huge ability, that law, to help us get in there and really fight that discrimination. And it's going to be a bit of a fight. It's going to take a while, but I think the energy on this panel shows that how many people are committed to making it happen. Thank you.
Absolutely. Thank you. Acting Assistant Secretary Coder.
Thanks so much, Bill. This has been a great panel and a great discussion today. And I've been taking copious notes here that I'm going to be sharing with my colleagues at HHS and at SAMHSA. And we stand committed to ending the discrimination. You're absolutely right, Commissioner. This is discrimination. You've said it, and we need to do something about it. So we're committed. Thank you.
Thank you. Congressman Kennedy.
Thanks again, Bill and Commissioner and Secretary and my good friend Tom and everyone who's participated. I hope you all stay engaged. We're looking to continue this fight, as I said, through the Kennedy Forum and Parity Registry and Parity Track and all of these tools. We're getting a lot of support from Secretary Walsh and Tom and others. I just say, you know, part of the problem here is we waited too long to treat many of these illnesses. I saw in the chat box. We treat these, to the point of my friend Paul Gianfrido, like stage 4 illnesses. If we enforce parity, then payers are going to say, hey, mea culpa, I cannot pay for all the critical care in this country right now. I just cannot pay for it all, which then makes them want to come up with a new mousetrap, which is maybe it's more cost efficient for me to do much better job at early screening, prevention, and early treatment. And that is the reason why we're putting so much pressure on plans to pay for this expensive care at the end of the day, because if they have the pain of having to pay for all that, maybe they're going to start to look for building a new way of building this mousetrap so that they're not stuck with such high cost to this crisis. But the pressure has to be brought in order for change to take place.
Absolutely. Secretary Walsh will give you the last word.
Thank you very much, Bill. Thank you for moderating what I hope was a great conversation. Tom, it's great to see you, and thank you for your work at SAMHSA. Commissioner, thank you for the insight that you provided with us today. I truly appreciate it. Patrick, thank you for leading this conversation and taking this fight to the country. I truly appreciate it as well. And two quick things. One is the Department of Labor is certainly committed to making a difference. It's lots of different pieces of the Department of Labor's jurisdiction that's out there for the country. But for me personally, this has been a passion of mine since I went into recovery in 1995, quite honestly, and I truly appreciate it. And secondly, a little off the path here. I know that lots of providers, thank you, and not providers, lots of advocates, maybe providers, thank you for being on here today. But if you're on here today and you're watching this because you stumbled across it, and you're in a place in your life that you need and you want to get some help, reach out to somebody. Even though we're talking about parity and we're talking about abuses and we're talking about not getting everything covered the way they should, that should not be a stumbling block for you as individuals that might want to get some help. So make sure you reach out to somebody today. If you're ready today, today's the day to reach out. And it's a day at a time. And I live my life a day at a time. Tom lives his life a day at a time. And I know Patrick lives his life a day at a time. And that's how we do it. So thank you for the opportunity. It's been such an honor to be part of this conversation today. And I look forward to the great work we're going to be doing in the coming months, in years ahead.
Thank you so much, Secretary Walsh, and for the wonderful advice at the end. And thank you all for taking the time to listen in with us. We know that these issues require passion and they require champions. And we're so excited to have had the chance to talk today with 4 fantastic mental health and substance use disorder champions. Thank you all and have a good day.